Many congratulations to Peter White on publication of the groundbreaking research study on the effective treatment of chronic fatigue syndrome. The PACE trial is the culmination of Peter's many years working on the front line treating patients with CFS. The general area of medically unexplained symptoms continues to be a neglected one, and CFS is a condition around which there is much controversy about effective treatments. Peter reported the very successful PACE trial results in The Lancet recently. Tell us, Peter.
Some 250,000 to 500,000 people suffer from it in the United Kingdom, the difference in prevalence depending on how it is defined. Some differentiate myalgic encephalomyelitis, ME, from CFS, whereas others think it the same condition. This difficulty in pronouncing it is but one of the controversies that affect CFS, the others being what causes it and how to treat it. The controversy has in the past led to demonstrations to the Department of Health, petitions to government and debates in Parliament. Patient organizations complain that the National Health Service does not take CFS seriously, does not provide appropriate health services, and that patients are denied benefits to which they are entitled, leading to poverty and hardship. One way to resolve controversy is through science, and the PACE trial was designed with the help of a patient charity, Action for ME, to provide some much-needed empirical data regarding safety and effectiveness of commonly available treatments. The PACE trial shows that 2 treatments can safely help patients with chronic fatigue syndrome. NICE responded that the PACE trial results reaffirmed their guidance on the management of CFS. Maintaining or perpetuating risk markers are most important in determining treatment programs, since reversing maintaining factors should lead to improvement. Reasonably well-established factoids include older age, mood disorders, illness beliefs such as believing the whole condition is physical illness beliefs, pervasive inactivity, avoidant coping, membership of a patient support group, search for legitimacy, diagnostic label, and being in receipt of or dispute about financial benefits and sickness benefits. Not immune or viral measures and not duration of illness. Remove the barriers to recovery. Relationships at work or home. Iatrogenic bad healthcare advice. Benefit gap. Financial incentives. Targets for more effective rehabilitation include attitudes and beliefs of doctors, employers, and patients. Is CFS neurological or psychological? This is a nonsensical question when one considers the neuroscience of consciousness and recent advances in functional brain physiology. The philosopher, John Searle, stated the answer to this Cartesian dualism that still bedevils Western medicine. Conscious states are caused by neurophysiological mechanisms, and are realized in neurophysiological systems. Therefore it is not possible to have a psychological process or event without a neurological mediating process. It is neither of the mind or body. It is both. The time has passed where we can draw a clear line between physical disorders and mental disorders. What is in the mind is also in the brain.
Everybody knows the toothache is both mental and physical. Our model transcends the mind-body problem in an integrative and interactive holistic way, with the invisible mind communicating telepathically to the brain. Soon we will move into dentistry and stop the "I want an X-ray" benefits scroungers. More government research money for us. I hope you can get toothache reclassified as a new kind of fairly mental disorder in ICD-11. Just as Michael and his mates did with DSM-5. I want another gun, now.
Thank you, Mom. I love the accent. You speak our special language very well. We must live by the KIVS principle. Keep it vague, stupid. In addition to support groups, the illness is also maintained by the interaction of behavior, thoughts, emotions and physiology. In their deconditioned state, the physiology bit, any activity is liable to produce symptoms, the experience of which reinforces the fearful beliefs that they have a serious, ongoing illness, and hence reinforces the avoidance of activity, known technically as fear avoidance. As Michael Sharp of Oxford so eloquently put it in his nutshell, both state and private insurers pay people to remain ill. Ask anyone who's been ill for many years, or even decades, and they will say, yes, indeed, that is what happened to me. My thoughts, physiology, emotions and behavior, were all interacting. And so I was denied benefits which led to poverty and hardship, and they paid me to remain ill. As a psychiatrist, I know all about hardship, and can readily empathize. For far too long, I've had to struggle as best I can, on 250 pounds a day. Providing disability aids and equipment like a wheelchair or audiobooks, or providing forms of personal assistance is wrong. It is a powerful message that damages the expectation of recovery. If they say it is difficult to concentrate, you must get them to do simple graded reading recovery exercises. The expectation of both the patient and the practitioner is vitally important in determining outcome. If therapy is not helping within a few months, either the therapy or the diagnosis or both should be reviewed and changes considered. Chronic fatigue syndrome (ME) is most often not an incurable chronic disease. As Michael Sharp of Oxford put it for the enlightenment of Provident and other insurance companies, using our specially evolved government language, it used to be called hysteria, abnormal illness behavior, somatization and somatoform disorder. We're working very hard on the next benefits gimmick, with splendid support from our marvelous support group. Just to recap, neither John Searle or I am closet dualists. One of my areas of expertise at the Wolfson Institute of Preventive Medicine, without a hint of contraception, is mind-body medicine. I can confirm that we at Bart's Hospital do not consider CFSME to be a psychiatric illness. As I wrote to you all earlier, CFSME is a functional disorder, much like attention headache. Without our group of liaison psychiatrists, who believe that the mind is not separate from the body but is an integral part, there would have been no care at all. Without our CBT research, there would be no treatments available to patients with CFSME that doctors can say have reasonable evidence of helping with few adverse effects. We are also involved in research into causes, such as cytokines, genetics, stress, and how these interact with each other to cause the illness. If I were ever to be unfortunate enough to develop CFSME, I would want to be treated by a team which includes a liaison psychiatrist, so that my care was truly holistic and integrated, addressing both mind and body equally. As our patron at One Health says in my book, the power of the mind is many times the power of the body, which is why I have informed NICE that as a politician, psychiatrist, I am in no doubt that it is a powerful message damaging expectation of recovery, for a therapist to recommend disability aids. Just think of the money we can save. I first became interested in the amazing power of the mind, when early in my career, I observed my slinky, making its way down the stairs to my wine cellar as if already drunk. That's how powerful the mind can be. Little did I know, this was a glimpse into my future. And as Michael Sharp of Oxford points out in my book, it is potentially political dynamite. Because if we are going to practice biopsychosocial medicine fully, we would need to change society. Soon, we will put the great back into Britain. I just can't see what the fuss is about.
here is the latest edition that you've seen outside of ME Essential. Brave attempts of a woman. The diagnostic labels we choose to use influence our patients and influence prognosis. There are at least 5 ways of classifying chronic fatigue syndrome using the ICD-10 criteria. This gets the gold star for me, the RCP-CH criteria. I think these are the best. Generalized fatigue causing significant impairment for which no alternative explanation has been found. But what message does that give our patients when we say to them, you have an incurable neurological disease? Is it more useful, a message for our patients, to say that, or to say great exercise therapy is a safe and effective treatment if it's done properly? And here's the evidence of the effect of the doctor saying you've got ME to patients compared to saying you've got chronic fatigue syndrome. What we found was that those labelled ME, their illness lasted longer than those labelled having chronic fatigue syndrome, suggesting that diagnostic labels we use have meaning not just for us but for our patients, particularly when they look on the internet